Dr. Shrivastava, who is a very well-known echocardiologist in the country. So he'll talk on heart failure with reduced ejection fraction. Clinico-Echo therapeutic navigation in diagnosis and management. It's a huge subject again, and lot of synergy and diversity are there in the whole topic. And as I was saying initially, it's a continuum. Over to Dr. Srivastava.
Thank you very much, sir. With luminaries like Dr. Das, Professor Gupta, sir, dear friends, all of you, thank you very much for this opportunity. So I'm going to talk about optimizing patient care, exploring evidence, especially in context with very sick word. This is my disclaimer, which says that if anything goes wrong, I am responsible for it. Not very sigwet, not Bayer, not anybody else. It is all my responsibility. So these are the details, and some in substance I have told you that this is something like you go for a home loan, and they'll give you this big a file, and you have to sign every paper, and then they say. So I picked up the papers and I started reading it. He says, Samir, do you want the loan or not? I said, yes. I said, but what is written in it? It says that if you don't pay the first installment, your car shall be impounded. Second, your wife's jewelry will be taken up. Third, you will be put to the jail. Do you want the loan or not? I said, yes, yes, yes. So these are what disclaimers are. Anyway, so coming back to the story of heart failure, it has its own ups and downs. And we know that there is nothing like a stable heart failure. All heart failures have a potential to get disenchanted from that label of stability to unstable anytime. So from heart failure with reduced ejection fraction, they may have several decades of stability. Then the ups and downs will come. But eventually, over a period of months to years, they all fall back. Where is the problem? The problem is that achieving foundational therapy is beta blockers, ACE inhibitors, ARNIs, beta blockers, ARNI, SGLT2 inhibitors, and MRS. So these are the four foundation pillars, and many a times these may not be optimally given, or the patient may not tolerate it, whether it is because of blood pressure, whether it is because of kidneys, whether it is because of electrolyte imbalance, or heart rate being unacceptably low. These are the reasons why many a times you can't give the so-called guideline directed medical therapy. Now, if you look at the eligibility, complete eligibility of 100 people with heart failure, good plus 80% of the patients are eligible for it, all four foundational therapy. But when it comes to quadruple therapy, which means ARNI, beta blockers, SGLT2 inhibitors, and MRAs, it's only 15% people who get it. And triple therapy, which is RAS inhibitors, beta blockers, and MRAs, only 41 patients get it. So these are the big fallacies. And another very disappointing statistics is that the projected global use of foundational therapy is that beta blockers are used only in 67% patients, MRAs in 43%, ARNI in 10%, and SGLT2 is less than 10%. So these are probably because of either clinical inertia, people don't want to accept polypharmacy, and comorbidities, which are a reason for resentment. This slide is going to be a recurrent theme in the topic today, because if you look at 1 year data of discontinuation, ACE inhibitors get lesser than 1 year, 38%, ARBs 33%, ARNI 26%, beta blockers, MRAs, and SGLT2 inhibitors, nothing crosses 50%. And this is again a very concerning statistics. Where are we? We are looking at a new, or now not so new now, which is another molecule which works on the nitrous oxide pathway, goes till the cGMP, which is the cyclic GMP pathway. If you look at ACE inhibitors or ARBs, they are inhibitors of the RAS. Beta blockers are inhibitors for sympathetic nervous system. ARNI again also, along with the RAS inhibitor, also does a naproxen inhibitor. SGLT2 inhibitors are there, but vericiguat is a potentiator of this pathway. How does it act? It acts in three ways largely. One is it reduces myocardial stiffness, reduces hypertrophy, ventricular remodeling, and fibrosis. These are all reduced, which is very good thing. Not only that, it has some positive impact on the kidney functions. It reduces renal fibrosis, it increases renal blood flow, reduces vasoconstriction, and improves endothelial function. So these are different trials with different molecules. Our focus this morning is Victoria trial, which was primarily only with ejection fraction less than 45%, and the number needed to treat for improvement was 24 only. So what is the ideal number needed to treat that all of us desire? 1. But 24 is also very reasonably acceptable, and this all fell into a statistical significance of 0.02. So we know that 0.05 lesser is a good statistical analysis. Now, if you want to contextualize risk among patients with heart failure compared to atherosclerotic cardiovascular disease, best of the cardiovascular disease will have much lesser risk of dying or worsening as compared to heart failure. So heart failure is one of the worst things, though the commonest cause for heart failure still remains as an atherosclerotic disease. But once that atherosclerotic disease translates into heart failure, the risk profiling worsens several times over. We know that when you have best of the treatment, still a lot of patients will die. This is known as a residual effect. And if you look at the 12 months all-cause mortality, there is a residual defect of about 10% plus. When it comes to post-hoc analysis of cardiovascular death or worsening heart failure, this is much higher, almost about 14-15%. And cardiovascular death or first heart failure hospitalization from Emperor reduced, this was almost about 15%. So we know that this is something which is a serious issue. Let's look at clinical effects. Patient experienced a decompensation event under optimal background therapy. This is background therapy is complete. Still, he gets something. Start on vericiguat. This is what the background information about that man is. Ejection fraction on echo was 25%. To start with, subsequently it came to 2021 and the ejection fraction improved by about 10% or thereabout. Continued to be symptomatic, and February 24 he had worsening. Now those are the parameters. We know that he is on sacubitril valsartan combination, empagliflozin, spironolactone, bisoprolol. And again, the issue is that once you have a blood pressure of 105/70, you know that you can't pep up things too many. And that's the reason why over and above whatever is best tolerated by the patient or whatever is maximally recommended by the guidelines and recommendations, you can't go further. And so what you do? You have this molecule of vericiguat. So you add on vericiguat, and when you look at this kind of a population across the board, when you add on, I think I'm going too slow. So let me just pick up. This is how you escalate it over a period of 2 weeks, 2 weeks, 2 weeks, 2 weeks. Within 4 weeks, you should reach 10. When it comes to blood pressure, it is very stable. It doesn't alter too much compared to whatever. Another scenario is when you have background therapy which is incomplete, and this is not suitable for completion, you can over and above add. So here is something where you know that potassium is 5 plus, the blood pressure, serum creatinine is 2.2, and you can't add too much of other things because you can worsen the potassium. And where are you landing up? You're landing up with another drug, which is vericiguat again. Like I said, this is going to be a recurrent theme. Now, if you look at the renal functions trajectory, doesn't worsen with vericiguat. So very safe for kidney function patients. Again, across the board, you find vericiguat is better. They may not be statistically significant, but numerically so, they are all on the favorable side of the line of unity and favoring very sigurd. Again, does it have impact on electrolytes? None whatsoever. So it's very safe even in hyperkalemia. And these are the rates of adverse events in, compared to the placebo. And you find that it is almost similar. So blood pressure, renal function, electrolytes, they don't change significantly. Last scenario, background therapy is incomplete, suitable for completion. Do you add vericiguat or not? You wait for the all four to be fundamental therapies to go up and wait for vericiguat to get into a heart failure hospitalization. No, you can do it all simultaneously, and this probably should become the fifth fundamental baseline therapy. So if you do this, you can do a vericiguat introduction even before discharge. This is the data for oral therapy with compared to quadruple. This is now quintuple therapy with vericiguat, and you know that it favors heart failure outcomes.
Samir, sir, we need to conclude.
So this is what it is. Last slide. So regardless of anything, additional production is given on background therapies. You can start straightforward and favorable safety and tolerability for all the profile. Thank you very much for your patience.
Thank you, Dr. Shrivastava. One quick question, and then we'll go to the next topic.
Sir.
Can I just have a very important, good presentation, Samir? I have just two important queries to ask. You mentioned in one of your slides, empagliflozin 10 milligram to be given when the EGFR is low. I'd like to see what is the cutoff point of the EGFR where you can give empagliflozin 1. Number two, this is our practical experience that a lot of patients of HFrEF, when the ejection fraction is low, when we subject them to more diuresis, either by using acetazolamide or we use Zytenex or ultrafiltration, their prognosis improves, and they really improve when you subject them to kidney transplant along with the heart failure. We'd like to have your views on this.
Sorry, when are you introducing Zytenex in? So cutoff level for paradoxically, when the EGFR is lower, SGLT2 inhibitors work better. So most of the trials initially were 60 to 90, then they came to 15 to 50, and these days people even on dialysis they can be given very safely empagliflozin. So there is no cutoff as such for SGLT2, which is true for even dapagliflozin. The second was that you want to give Zytenex in which patients, sir?
All the patients who have a low urine output and they are congested, they are wet patients with heart failure with reduced ejection fraction. In these patients, if we give Zytenex or acetazolamide, the diuresis improves and the prognosis improves. We'd like to have your views on it.
So where was the catch? The catch was give Zytenex and their kidney functions worsen. You give Dimox and their kidney functions worsen, but not in a setting of reduced ejection fraction. Why so? So we are going to into very basics of fundamentals of cardiology. Frank Starling law. What does Frank Starling law says? Frank Starling law says that the contractility of a myocardial fiber is directly proportional to the initial length of fiber within physiological limits. This within physiological limits is one of the biggest catch points. Heart is large. They have crossed, most of the fibers have crossed that physiological limit. There is no contractility available. Now what do? You give diuretics regardless of which one. You reduce the size of the myocardial fiber. The moment you reduce size of myocardial fibers, many of these beyond the physiological limits come within the physiological limits, and now they start contracting. And when they start contracting, your organ perfusion improves, your blood pressure improves, paradoxically so. So don't be scared to give diuretics which can worsen kidney function just because the urine output is bad. And rightly, your assessment is absolutely right. Clinically, we have seen improvement, and we have a scientific reason for that.
Thank you, Dr. Shrivastava, for your beautiful presentation. And let us give a big hand just to add to this, you can. I'm calling the next
Dr.
person.
Das is saying get out of here.
Yeah, just to add to it, actually, as per the guideline, diuretic should not be given after the volume overload is over. That is number one. And for SGLT2 inhibitors, it is 15 millimeter EGFR, below which you should not use the SGLT2 inhibitor. So these are as per the guidelines. Now, having said this, I think that the discussion will continue. Let us